halfway, like we talked about with the lower extremity. And like with the lower extremity, common problem is people will stop here. Shoulder to elbow, halfway. So make sure you get high enough. First thing we always do is anchors, make this tight. Why do we have to make the forearm muscles tight? So it's not too tight, right? Okay, 3 to 4 anchors, overlapping each one by a half. Follow the contour of the body. Okay? Like, seriously. Any day now.
Where's yours then? Let me see. Oh, yeah, a little bit going on here, a little bit. I think
you two stop flirting and
he likes me. You can't do it. This is good for it.
Alright, so if we're going to do hyperextension, the most common one for elbow is we look at the front, okay, so in anatomic position, we put the elbow in slight flexion, about 10 or 15 degrees. Not too much flexion, we don't want it fully extended, just a little bit, okay? And we measure anchor to anchor. And just like we did for the knee, we create our fan. They can be a little spread out because we got some pretty decent surface area to deal with, unlike our toes. Alright, come back, elbows with a little bit of flexion. Come on, anchor down the top part, proximal portion, have them tighten the muscles up, and get it anchored down. Full tension, so we create a little gap here, okay? Anchor this down, tighten the forearm muscle. 1, 2, he's pushing into my gut that helps me keep his arm stable, right? Then we would cover it with elastic tape over the top just to make it all tie together and look pretty. We're not going to do that here. And he goes to extend and he's limited. He's going to slip some because we're not taping to the skin because we're taking care of each other in here, right? But that's it to the skin. That ain't going nowhere. It stops that. Same principle. Valgus means distal segment points away from the midline. So that's our normal position of the elbow. So if we have a valgus injury to the elbow, we have injury to the medial collateral ligament, or the ulnar collateral ligament, because the ulnar is always little finger side, right? So we would do exactly the same thing from a pre-wrap, clean dry shave skin, little anchor to the skin, proximal and distal anchors. We would measure gap or anchor to anchor, and we would put the fan behind the medial malleolus, okay? Or not medial malleolus, medial anaconda, excuse me. For varus injury, which would be something like that, where we have injury to the lateral collateral or radial collateral ligament, we would put it behind the medial epicondyle. On the knees, remember, we put the crisscross right on the middle of the joint line on both sides, right? The elbow is a little bit different anatomically than the knee, so we have to put those crisscrosses a little bit posterior. So we find medial and lateral epicondyle respectively, and we put that crisscross just behind each of them. So the application is the same, and then we anchor things down. One thing that many of you who did the knee tapings for the lower extremity practical exam is you didn't have people contract their muscles before, during the anchors, and the first time